Jay said we wanted. Go over there, Jay.
We will present today on the principles used for assessing hemodynamics by echocardiography. So the first slide is showing the pressure and its units of measurements as you see here. Pressure is defined as force per unit area, and so if we use the SI system and we express force in dynes or newtons, and then the area in centimeter or meter squared. Pressure could be expressed in dynes per centimeter squared or newton per meter squared, but could also be expressed as pascals. 1 Pascal is given by 1 Newton per meter squared. There are other expressions that will be of interest to us as we proceed, and so one can look at other derivations from this simple definition. Since force is given by the product of mass and acceleration according to Newton's second law, we can also write the expression as mass times acceleration divided by area. And mass is given by the product of density and volume. And so we have volume in the numerator and area in the denominator. And if we reduce these terms, it becomes a distance. And so pressure is given by the density of a given substance, the free fall acceleration, and the height. For water and for mercury, we can estimate the pressure exerted by 1 centimeter of water, given the density of water is 1, or by 1 millimeter of mercury, given the density of mercury is around 13.26 or so, gram per centimeter cubed. And many times we are interested in converting centimeters of water. And so if we know 1 millimeter mercury exerts pressure of 1,333 dynes per centimeter squared, the height that would result in 980 dynes per centimeter squared, or 1 centimeter of water, is therefore given by 0.738 millimeters of mercury. Important when we do communications, for example, physical exam will give you the height or the pressure in terms of centimeters above the manubriosternal angle. But many times when we do pressure measurements invasively or estimate them non-invasively, it's in millimeters mercury. So that's something worth remembering. Flow can be assessed as the amount of volume that fills the cylinder. And so the volume of the cylinder is given by the product of the cross-sectional area and the height. Since this is volume filling the cylinder in a unit of time, we can say that it is the product of area and velocity. And you can see that it would have the units of volume per unit time. If the area is assumed to be a circle, it's the area of a circle. If it's assumed to be an ellipse, it's the area of the ellipse, as you see in these two expressions. For practical purposes, for most calculations that are used, we use the circular, not the elliptical assumption, and there is little to be gained in terms of accuracy if you were to use the assumption of the cross-section being an ellipse. Next, let us examine flow in a tube, and for us the tube is a blood vessel. First, we'll talk about flow in a rigid tube, not in an elastic tube as in the blood vessels. And so there is a distance within the tube where the flow will change its profile to a parabolic profile as you see here. Why this is happening? It's happening because there is resistance between the layers of fluid and the edge or the wall of the tube that will result in slower velocities. And as we move from the center to the outer edge, the velocities will go from the highest values to the lowest values till it reaches 0 when there is the edge of that tube. The distance over which the parabolic profile is formed is referred to as the entrance length. When we talk about motion for solids, we think of friction. For liquids, we think of viscosity. And viscosity is a factor that offers resistance to the flow of fluid. So higher viscosity translates or means really higher frictional forces. Blood is described as a Newtonian fluid, and what that word means, it means that there is a linear relation between the shear tension and the velocity gradient. The velocity gradient we are talking about here is a spatial velocity gradient, the one we just talked about, how the velocity changes across the cross-section of the tube. Mathematically, it can be expressed by this expression, whereby the stress per unit area is given by the product of viscosity and the velocity gradient, the spatial velocity gradient. Since we are interested in units of viscosity, we rearrange this expression, and you can see that the stress, which has the units of force per area or Pascal, multiplied by seconds, since the distance cancels in the numerator and the denominator, are the units of viscosity. So the units of viscosity are the Pascal second. Now let us look at Poiseuille's law. We are looking at flow through a cylinder with a circular cross-section. However, when we think of that, think of concentric layers of the fluid with gradually increasing radius. So we have a small radius r, and the maximum radius is a, which is from the center of the tube to the outer edge. And as you see on this cross-section, the velocity is 0 at the edge. In the center, the velocity is maximum, and in between you will have values between the maximum velocity and 0. If the pressure at point 1 is higher than the pressure at point 2, flow will take place in the direction from point 1 to point 2. At equilibrium, the pressure force is going to be balanced by the friction force. And that's the starting point for deriving Poiseuille's law. And so there is the pressure, which in terms of force is pressure difference multiplied by cross-sectional area. And for this one, when we think of the frictional forces, we think of the stress multiplied by the surface area of a cylinder. The surface area of the cylinder is given by the product of the circumference and the length of the cylinder. We rearrange this expression, and we can see that the pressure difference multiplied by the radius divided by twice the length is given by the product of viscosity and that velocity gradient, the spatial gradient. We are interested in obtaining a term that characterizes the velocity, and so we rearrange this expression again and we integrate. And when you complete the integration with the limits that you see here, you end up with the maximum velocity being directly proportional to the pressure gradient, the fourth power of the radius, but inversely related to the length of the tube and the viscosity of the fluid. We are interested in quantifying flow, and so we can express that as the product of the area and the mean velocity. It can be shown that the mean velocity is about half of the maximum velocity, and so we replace the term we obtained for the maximum velocity from the previous slide here and divide it by 2, and we end up with the classic Poiseuille's equation. One way of looking at it, instead of looking at flow, is asking the question, what is the resistance to flow? And the resistance to flow is directly related to the length of the tube, directly related to the viscosity of the fluid, but inversely related to the fourth power of the radius. 8 over pi is a constant term. That's a very useful expression for us as we think of flow through blood vessels, including coronary vessels. Now, when we look at this Poiseuille's expression, which we obtained in a rigid tube, and we ask the question, does it apply to flow in the human circulation? What are the assumptions that do not necessarily apply? If you look at the previous expression, the viscosity here is assumed to be a constant. And that is in general correct, except when you start looking at very small blood vessels, less than 0.5 to a millimeter in diameter. Here, the proportion of red blood cells to plasma increases, and therefore the viscosity changes. And luckily, these vessels are not examined by Doppler. The assumptions that we looked at is laminar flow, not turbulent flow. And if you're looking at the normal circulation, except for a short distance in the pulmonary artery and the aorta, flow is laminar. All the assumptions were derived based on a circular tube where the area is not changing. For tapering vessels, this is not valid. If you also look at the issue of whether the vessel area, cross-sectional area, and diameter increase as flow takes place, this happens in the human circulation, but obviously we did not entertain that in the derivation of the expression you just saw. This results in an error of at least 10%. Finally, we concerned ourselves with steady flow, whereas flow in the human circulation is pulsatile flow with a varying velocity profile. Notwithstanding that limitation, a temporal mean may still give reasonable approximations. So these are the assumptions and how they apply or do not apply to the human circulation. Another term worth looking at is the Reynolds number. The Reynolds number, the higher that number, the greater the likelihood of turbulent flow. It reflects the balance of inertial and viscous forces. Viscous forces could be represented by viscosity, and we just mentioned that viscosity has the units of Pascal second. The inertial force could be represented by the product of density, velocity, and the area. The larger the diameter, the greater the volume of fluid that is passing by. We can replace density by mass over volume, and we can replace further the mass by force over acceleration, as you see in this term. Now we can reduce diameter and volume to area, and so you can see that the numerator reduces to force divided by area, or Pascal multiplied by second. These are the units of the viscosity in the denominator, and so this is a dimensionless index. It doesn't have units. We already looked at the flow and how to quantify it. Let us ask, what are the potential errors that come in the calculation of flow? Flow is based on a correct measurement of the diameter, and so if there is an error in the diameter measurement, there will be an error in the flow calculation. The assumption was made that the cross-section is circular or elliptic. If it is neither, then there will be an error here as well. We assumed that the flow is steady and that it doesn't vary. Obviously, the flow is phasic, and the instantaneous area of a given vessel or even given region in the heart is not constant, but varies, for example, the LV outflow tract area over the duration of systole. We looked at the impact of absolute flow and changes in area. It was shown in vitro studies that the area can actually change if you change the flow towards larger amount of flow. This aspect is being made use of in the calculation of aortic valve area under different flow conditions by infusing positive inotropic drugs. We have to sample flow or the velocity and the diameter at the same site. If they are not at the same site, then there will be errors. Also, there are approaches where one can go directly to measure the area instead of the diameter. Needless to say, if there is an error here in the area measurement, that will also translate to an error in the flow calculation. A frequent question that is asked sometimes is, how much an error in diameter results in an error in the area calculation? And this is using simple algebra. You can see that the error in the area calculation is twice the error in the diameter calculation. To minimize the diameter measurement errors, we want to zoom and magnify as opposed to measuring the diameter on a larger scale. We addressed errors in the quantification based on area measurements. How about velocity measurements? The first assumption is a uniform spatial velocity profile. In general, this holds, but once you start looking at turbulent flow, there can be problems with that assumption. We tend to think about velocity flowing in one plane, perhaps. You have to remember that it's a 3D velocity vector that one would be most interested in. The signal strength, if you have a faint signal or a clear signal, that can determine whether you catch the peak value or underestimate that. Because flow can be measured at different time points during the exam. For example, the LV outflow tract diameter is measured early on in the exam, but flow through the LV outflow tract is measured later on when the sonographer or the physician is working to acquire apical views. If the actual heart rate or the hemodynamic status has changed between these two conditions, then that can lead to an error. And finally, the assumption of continuity. The assumption of continuity really holds, except if you're thinking of, for example, measuring flow at the aortic root above the level of the coronary arteries, and then assuming that this is the same flow that leaves the heart at the level of the LV outflow tract. Obviously, above the level of the coronary arteries, some flow has already happened into the coronary circulation. The calculation of stroke volume is based on the product of cross-sectional area and velocity time integral. We already talked about how to calculate area, assuming a circular assumption. And the velocity time integral is something that can be measured online with the ultrasound system or offline, or if there is a need for approximation, you can assume that it's a triangle and work with it as the area of a triangle. Cardiac output is then the product of stroke volume and heart rate. These measurements have been used to look at the effects of drug therapy on cardiac output. They have been used to look at the effect of different pacing modes on stroke volume, physiologic changes that happen in the circulation with pregnancy and labor and after delivery, fetuses and neonates, including different phases of life for the neonates, different time intervals, and also with exercise Doppler. Certainly with exercise, satisfactory data acquisition can be more challenging. Aside from these applications, they have also been used to look at shunts calculations, calculations of regurgitant volume, valve area, and ejection fraction. For example, there is the measurement of the LV outflow tract diameter in the parasternal long axis view, and it can be combined with the time velocity integral through the LV outflow tract to calculate stroke volume this way. You can also look at flow through the RV outflow tract. This happens to be a parasternal long axis view showing the RV outflow tract, the pulmonic valve, and the proximal portion of the pulmonary artery, and you combine it with RV outflow tract time velocity integral. Likewise, you can quantify mitral inflow based on the mitral annular area and flow at the level of the annulus. During the exam, flow should be acquired at the level of the annulus and the tips, but the one that is used to quantify flow is at the level of the annulus. This is illustrating how the concept behind calculating mitral regurgitation volume. If we say that the total stroke volume that the ventricle ejects from end diastole to end systole goes in two directions, back into the atrium as the mitral regurg, and forward into the ascending aorta as aortic flow. It follows that the mitral regurg volume then is the difference between the total stroke volume and the flow that goes through the LV outflow tract. That's an example. It's a patient with severe mitral regurg due to a flail segment. Colored Doppler shows a lot of turbulent flow occupying a good size of the left atrium. Here we get the mitral annulus. We get the mitral annular time velocity integral. We get to look at the LV outflow tract diameter. We get to sample flow through the LV outflow tract. And these are the measurements that you see here for each one of them. And so mitral valve stroke volume is 113 cc's. The aortic valve stroke volume is 42 cc's, and the reason the mitral exceeds the aortic flow is the mitral regurg volume corresponding to 71 cc's or milliliters or 63% regurgitant fraction. Can also be used to quantify aortic regurgitation. We see in this case flow through the LV outflow tract is 82 milliliters, whereas flow through the RV outflow tract is 54 milliliters, resulting in a regurgitant volume of 28 milliliters and a regurgitant fraction of 34%. Moving from flows to energy and pressure gradients. Still, we will need flow in some of the derivations and to have a better understanding. Energy is defined as the capacity to do work, and so work is defined simply as force times distance. And in fluids, we are interested in pressure, so it's pressure times area times distance. Also, it could be expressed as pressure times volume, as you would expect from the product of area and distance. We can replace these terms and rearrange them to get two terms that are of interest to us. First is the kinetic energy, and that is half mass times v squared. For fluids, we use volume and density in place of mass. And the potential energy, which is related to the density of the fluid, in this case blood, 1.06 gram per centimeter cubed, free fall acceleration, which is 980 centimeter per second squared, and the height relative to the center of Earth. Also, an important principle to look at is Bernoulli's law, and it's really saying that energy is conserved. But before we go into the full Bernoulli expression, let us look at utility of the continuity equation. Flow at these 2 points is equal. And it follows, since the flow is given as the product of the area and the velocity, that the velocity will be higher in the cross-section with the smaller area. And also kinetic energy would be higher here. This continuity expression is used to quantify aortic stenosis and calculate aortic valve area. Now let us go to the full Bernoulli equation. We can express the total energy as the product of pressure and volume, the kinetic energy term, and the potential energy term. Since energy is conserved, the sum of these forms or these terms at point 1 has to be equal to their sum at point 2. Since they are at the same height, we can ignore the potential energy term, and you can rearrange this expression to look at the pressure gradient is equal to half density multiplied by the square of velocity at point 2 minus the floor of velocity at point 1. However, if the velocity at point 1 is so much less than that at point 2, we can ignore it and we end up with the modified Bernoulli equation. It can further be shown that if we want to express the pressure in millimeters mercury and the velocity in meter per second, we can change this term and say the pressure gradient is given by 4v squared. There are limitations to the modified Bernoulli equation. They stem from the modifications which were introduced to simplify it. If you take a look at the first line on this slide, you see the kinetic energy term, but there is also a potential energy term, inertial term, and there is a resistance term. These terms are being ignored when we say the pressure gradient is equal to 4v squared. If you're looking at the normal circulation at valve opening and closure, except at valve opening and closure, the inertial term can be ignored. If you're looking at turbulent flow, the inertial term may not be ignored, meaning it can affect the accuracy of the calculation. Also, if the velocity at point 1 is at least 1.5 meters per second, you should use the full term, which is v2 squared minus v1 squared. Clinical applications for the pressure gradient calculations. We use them in daily practice to estimate pulmonary artery pressures. gradients across stenotic valves, gradients across prosthetic valves, intracavitary gradients, the concepts of DP/DT using the mitral regurg jet as well as the tricuspid regurg jet, in addition to estimations of LV end diastolic pressure based on the aortic regurgitation continuous wave Doppler and left atrial pressure based on the continuous wave Doppler recording of the mitral regurgitation jet. These assumptions will be shared with you on these slides. So that's the PA systolic pressure. In the absence of pulmonic stenosis, the RV systolic pressure should be the same as the pulmonary artery systolic pressure. And so the difference between RV systolic and RA pressure is given by 4V squared, and the velocity here is the tricuspid regurg. And it follows that the PA systolic pressure could be estimated as the product, as the sum of the 4V squared of the peak TR velocity meter per second plus your estimation of right atrial pressure. Can also be used to estimate PA diastolic pressure. Here the difference between PA diastolic pressure and RV end diastolic pressure is given by 4 multiplied by the end diastolic velocity of the pulmonary regurgitation jet. And we make the assumption that the RV end diastolic pressure is equal to the right atrial pressure, and therefore the PA diastolic is given by 4V squared again. Notice this is the end diastolic velocity, not the peak, plus the right atrial pressure. Because the end diastolic velocity is frequently a low velocity, this estimation of PA diastolic pressure is sensitive to errors in right atrial pressure. We mentioned that we can use continuous wave Doppler to calculate the peak gradient and the mean gradient for an aortic stenosis jet, and this is the aortic stenosis jet from the suprasternal notch, with a peak velocity about 4 meters per second corresponding to a gradient of 64 millimeter mercury. You can also use the flow across the mitral valve in diastole, the continuous wave Doppler, to quantify the peak and mean gradient of a mitral stenosis jet. All these approaches have been validated invasively against simultaneously acquired pressure measurements. That's an example from a patient with a mitral Hancock prosthesis looking at the gradient by Doppler and the corresponding gradient by cath. The patient has atrial fibrillation, and therefore you see variable RR interval, variable flows, and variable gradients. Nevertheless, you can see how the mean gradient corresponds very well by Doppler to that obtained by cath. Again, we want to align properly with the direction of flow to obtain and achieve these results. The dynamic gradient can occur in patients with dynamic obstruction, like hypertrophic cardiomyopathy. In this case, the peak velocity is 6 meters per second, corresponding to a peak gradient of 144 millimeters mercury. We mentioned the DP/DT calculation. For routine work in the lab, we do not usually resort to this, but for research purposes, it may be looked at as a metric of LV systolic function, in addition to other measurements as ejection fraction, strain, and so on. And what happens is we want to measure the pressure difference between 2 time points divided by the time interval between them. And so if we say we are limiting the velocities to the velocity at 1 meter per second and at 3 meters per second, the difference between them would be 32 millimeters mercury divided by that time interval, in this case 67 milliseconds, gives you a markedly reduced DP/DT in this ventricle with severe systolic dysfunction. Likewise, you can use it for tricuspid regurg, and rather than emphasizing the calculation, I want to emphasize the slope here. You can see the sharper rise in pressure in a better performing right ventricle than the slowly rising pressure in a ventricle with systolic dysfunction. Last, I will share with you an approach to estimate left ventricular end diastolic pressure as shown here. The end diastolic velocity is 3.6 meters per second. And we go to this expression and we say the diastolic blood pressure minus end diastolic pressure in the ventricle is given by 4V squared. If we measure the diastolic pressure at 70 and we know the peak velocity, we can estimate the end diastolic pressure here to be 18 millimeters mercury. This is not necessarily an accurate approach for end diastolic pressure, but I am sharing it with you to emphasize applications of the modified Bernoulli equation. Thank you and happy to entertain questions. Hmm? Yes, I cannot. Okay.
Can you ask them if they have any questions?
I can ask them.
Yeah.
Okay. Happy to entertain any questions. If you have a question, please speak up so I can hear. Okay. So then, okay, we can end then. Okay, thank you.